All right. Uh, Very good morning, everyone. Welcome to ISG Masterclass, yet another lecture in a GI series, which ISG has planned for all of you for last about 6 weeks. This is the seventh lecture in that series, and this lecture is by Dr. Uh, S.K. Sareen, and on very important topic, how do we diagnose and treat hepatitis B virus in 2020. All of you know Dr. Sareen. He's one of the most well-known uh, hepatologists in our country, not in our country, but whole of Asia and globally. He's so well recognized. His work in liver disease have been exemplary. And I can simply say that he's the star of our country. And he consented to speak to us on this topic, which is so common, not only to gastroenterologists, but also to physicians. As we know that uh, about 2 to 3% of our population has hepatitis B virus infection. And most of these patients come to physicians and only some come to gastroenterologists. How do you make a diagnosis and how do you treat them is an extremely important subject. And we thought this is one subject we must deal with in masterclass so that everybody gets the overview of this topic. And for that, we have one of the best name in our country, Dr. S.K. Sareen. With this, I'll invite Dr. Saraswat to speak to you before we invite Dr. Sareen to speak to us on this topic.
Thank you, Govind. Good morning, everyone. All of you who are logged on from different parts of our country, and I think many of you are also there from our neighboring countries. As Dr. Govind has just told you, we are continuing our series of ISG masterclasses, which will go on till the third week of May, and then we'll shortly be announcing programs or the future programs in this series. It's a great pleasure for all of us to welcome Professor Sareen, the Global Authority on Hepatitis B. He's the chief author of the APASL guidelines that many of you are familiar with and are following. And he will be talking to us about hepatitis B diagnosis and management in 2020. As you know, the format is that the lecture will go, the Professor Sareen will give his talk for the diagnosis component, and then that will be followed by questions. We are very happy to welcome Dr. Kaushal Madan, Secretary of the INASL, Indian National Association for the Study of the Liver, who will be moderating your questions that will come in on the chat box after the first segment. And then after Professor Sareen completes his talk, whatever other questions that have come in on the chat box will be dealt with by all three of us, Govind, myself, and Kaushal. And thereafter, I think if anything remains, we'll be sending answers to your questions on the email. With these few words, I will not stand between you and the star of the day, and I request Professor Sareen to please initiate his talk. Thank you.
Thank you, Dr. Saraswat, Dr. Govind, and Kaushal for inviting me and giving me opportunity to get connected. I must compliment ISG for this huge initiative. I am wearing a mask just to give you an idea. These are COVID days, and we will remember these. I'll bring you greetings from the Institute of Liver and Biliary Sciences, and I'll try and cover some aspects of hepatitis. It's a huge topic. I have nothing to disclose except that we have very good, young, bright faculty, and we're looking for brighter people. And our residents are ranked second after AIIMS Delhi by the UGC for second year in consecutive research and scholastic output. I will cover the virus, the viral diagnostics, assessment of age of virus and disease, and then we'll stop for a chat. Here are three cases you might have seen. These are 30-year male gynecologist going to US for routine check. Incidentally, was detected to be HbA positive. We call it IDAHS, normal ALT, E antigen positive, high DNA. We don't know whether we should do biopsy or we should treat or wait. A diabetic goes for his routine checkup, is found to be incidentally hepatitis B positive, has raised ALT, is E minus, has low DNA, has a high fibroscan, and biopsy is F3. Should we treat a low DNA? Third, it's a post-chemotherapy man, 57-year-old, has a low albumin and has high bilirubin and high ALT. Do we do DNA? Several of these questions come every day. When I just made a little count, HBV can present in more than 500 combinations, and there is not one guide. So I'll run through some basics and some practical tips for you. This is an old but very useful diagram. This is a hepatocyte came Nature Reviews. Just to tell you, hepatitis B, the double-stranded DNA virus, gets inside into the cytoplasm and gets into the nucleus where it multiplies. We'll come to it again and then comes out. And the CCC DNA, it stays inside into the nucleus. Unless the cell dies, there is no way hepatitis B can be removed. Remember, if it is more than 6 months, it is chronic infection. So the hepatitis B virus is an incomplete DNA virus. As you can see, it's not complete. There is a portion which is incomplete in this. This is the genetic material. And a small HBV RNA now is also a genetic material. The marker of replication and infection is HBsAg. The antigen certainly gives you how much the virus is multiplying, and anti-E gives you a non-replication status, but there are challenges. I'll come to it. A marker of past exposure is anti-core against the core antigen. Marker of protection is anti-HBs more than 10. And marker of injury is STPT. Let's revise them one more time. Infection says HBsAg positive, HBV DNA positive. And now I have added hepatitis B core-related antigen, which is, we'll come to it again. These are markers of infection. Replication is E antigen, DNA, HBV RNA, and IgM anticore. Exposure is anti-HBC, IgG, anti-E, and an exposure can be anti-HBs. And the marker of protection is anti-HBs. Please remember, some more things will be added to this as new diagnostics. The question commonly is, you have a patient who brings you a report, or you find him before surgery or endoscopy HBsAg positive. What next? 3 things need to be done. Does he have liver disease? What is the status of the virus? And is there inflammation? How do you assess fibrosis, cirrhosis, liver cancer? You do by liver function test, especially albumin and INR, AST to platelet ratio, and FIB4, an ultrasound or a fibroscan. You also assess inflammation by ALT. I'll combine the two and put before you incidentally detected asymptomatic HBsAg positive subject, IDAHS. The term was coined by ISG in 1999, and I must give compliment to ISG. It had a special supplement in 99. For the first time, ISG said that we should now do not use the term carrier, and we should use this because it removes the stigma from the people's mind. Now, if you have such incidentally detected people, they are young, they have a high DNA, and even if they have a normal ALT for 12 months, you do these patients, they are highly infected. And a liver biopsy, if done in such people, you will see that F2, F3, or F4 fibrosis is seen in about 40% of the patient. And 2/3 also have inflammation. So what you call as an immune tolerant or hepatitis B carriers may have actually liver disease. So it was in 99, as I said, Indian Journal of Gastroenterology, it was proposed chronic HBV carrier is a misleading term. It must be replaced by chronic HBV virus infection. And this has been subsequently accepted by almost all societies. We were at fibrosis assessment, and for that it is important to know how the virus has come. The first studies by my teacher, Professor Nayak, was in Journal of Medical Virology. 8,500 females were screened. It showed 88% transmission from mother, from 88% transmission was horizontal. It was not a mother-baby transmission. In our series, which was published in 2011 of about 20,000 mothers, those who were positive were only 1.1%. Transmission was seen in 67%. Those who had high DNA, that is about 10 raised to power 5, 100% transmit. What is most important is 3/4 of HBV in India is from mother to the baby, perinatal transmission. Therefore, role of pediatricians is paramount. We did a study when Dr. Satpathy was with us. Now he is a very famous star in the US. 116 hepatitis B positive children were taken, and we studied their mothers. And what we studied in their mother, HBsAg, anti-E, IgG, anti-core, marker of past exposure, marker of prior replication, and anti-HBs. 3/4 of the mothers had evidence of HBV infection. They may be HBsAg negative, but they had other markers indicating possible mother-baby transmission. So how do you age the virus? Has it come horizontally through blood transfusion, through injections, needles, or sexual exposure, or it has come perinatally? If it has come perinatally, the age of virus is same as the age of the individual. If he is 32-year-old, the virus is 32-year-old. And that makes us understand why fibrosis occurs in 27-year-old people, and it can be extensive. So we must understand to age the virus. We have to do either biopsy or do a fibroscan. We were doing biopsies and I'm still fond of it, but many people do fibroscan. Let me show you the problems with fibroscan. Normally 8 is considered as stage 2 fibrosis, and less than 7.4 is stage, less than 2, 1, or between 1 and 2. And this large study showed that if you have normal ALT and liver stiffness is less than 6, then do a periodic follow-up. 6 to 9 in normal ALTs were considered as gray zone, nothing to be done. Only above 9 considered as advanced fibrosis, or about 12 as suspected cirrhosis. Of course, with abnormal ALT, these values change. But 6, all of us believe, is okay. And 6 to 9, you don't bother. But let's look at the data. When you have in gray zone, you have patients with liver fibrosis and those who have advanced fibrosis, that is above 9 to 12, there is no difference. Of course, above 12, you have cirrhosis, and less than 6, you are okay. Still, you have some insignificant, but the gray zone is actually a gray zone. So the new message I want to give you is that do not always believe fibroscan. Generally, above 8 is considered to be significant. I use and Apostle uses 8 as the cutoff for indication for liver biopsy. And remember, 50% of those in gray zone can have fibrosis. Now, something on viral diagnostic and inflammation. Now, we all know that the virus is in the nucleus of the hepatocyte. Now, this is a covalently closed circular DNA. What is it? It is when the virus has lost its polymerase. Now, this replicates and gives you a sgRNA, which makes the surface antigen hepatitis B antigen. It also gives you a pre-core RNA, which gives you correlated antigen and E antigen. It also gives you a pre-genomic 3.5 kb RNA, which makes your HBV DNA as well as HBV RNA. Now, these are all easily tested, and some of the virus can also get integrated. So, what are we testing routinely? HBsAg and HBV DNA and HBe antigen. But yes, we also now will need to know core antigen, which is a marker of replication of the cccDNA, also RNA, which is a marker of replication, and HBsAg, which is a marker, and I'll show you, of both HBsAg specific RNA and also of the whole virion. Let's look at these. These are the spheres, these are the rods, this is the empty virion, this is a Dane particle which has the virus inside, and this is an HBV RNA, and this is just a core-related antigen. Currently, if you are quantifying the subviral particle, that is HBsAg, it is 10 raised to power 14. And if you are doing empty virion, no DNA, it is 10 raised to power 11. And the DNA, Dane particle, is 10 raised to power 9. 5 log more, it's like 10,000 times more HBsAg is produced per viral particle. And this works as the decoy. Pure HBsAg protein will exhaust your T cells. Please remember this. So what we are measuring is just HBV DNA, HBsAg. What we actually need also to know other things like correlated antigen and to know that HBsAg can be a decoy. Tomorrow, one of the good markers is HBV RNA of replication from cccDNA. These diagnostics have a role in the natural history and our understanding. There are 5 phases if the mother-baby transmission has occurred. So first stage is the what they call as immune tolerant, is the low replicative stage, high replicative and immune tolerant stage. You have a high DNA level, surface antigen is positive, E antigen is positive, and ALT is normal. About in India, I would say 15 years, in the West and others is 20 years or so. The person remains E antigen positive, but it starts having rise in ALT. Some flares can come. When the flares come, surface antigen comes down, DNA comes down. Then there may be stage, maybe for 10, 15 years it is inactive. In some it never comes. And then again there are phases of reactivation, and now you see that DNA comes earlier and then comes the ALT flare. After a while, either the virus is integrated or not, and the E antigen positive becomes anti-E anytime. Surface antigen positive may become negative, but then it is seroconversion, but generally it doesn't occur. And anti-HBe positive and low level replication always continues. The potential future biomarkers, as I said, will be HBV RNA, the E antigen quantification, core antigen, core-related antigen quantification, HBV RNA, and core-related antigen. These are all markers of transcription of cccDNA which remains in the nucleus. We cannot access it, we cannot measure it. So how do you measure? By doing the RNA, which is 3 log lower than DNA generally. Why should we do E antigen and E antibody? In nowadays, me, Dr. Tyagarajan, Dr. Acharya, Dr. Chawla, all of us just used to have E antigen positive, E antigen negative. DNA doing was not easy. So the way we were classifying was E positive, E negative. Of course, now we know they have high DNA. This is a rather low DNA. In India, 60% are mutant viruses. They are E minus. But the importance of this lies in the genotype. Genotype A is generally E positive. Genotype D is generally E negative and has a stop codon at 1896. These are patients who have an aggressive course, they have a poor response to interferon. Remember, they will need more nukes than interferon, and these patients need more of interferon. So, classically, you define a wild type virus, which is E positive, you seroconvert to E negative, and in mutant, already E minus has a low level of DNA but more aggressive course. There are more flares in this. So I'll now briefly summarize this part, how to write diagnosis in a chronic HBV infected subject. We started with, suppose somebody hepatitis B positive comes to you, what do? So after you have done something, sub labs or assessments of the liver and inflammation, what do? So you will have to first say he is chronic HBV infection. Avoid using the term carrier. You may use, if the patient has no symptoms, incidentally detected asymptomatic HbSAg positive subject, IDHS. It gives him an identity without a stigma. If he has symptoms, of course, he will not fit into this. Then you have to say chronic hepatitis B, which is generally a virological, clinical, and a histological or a fibroscan based assessment. So, what are the components? What is the type of virus? Is it wild type or a mutant type? What is the load of the virus? Every patient who is infected makes about 10 raised to power 12 or 13 viral particles. It depends on the immunity, how much is the level which is there in the blood, but production levels are not changed. So DNA level 3, you have to also do quantitative HbSAg, which is 5 times generally higher than the DNA level, 5 logs. Transmission, you have to define the age of the virus, and you also have to see, it is acute hepatitis B or reactivation. Inflammation, ALT is normal or high, and how high? Fibrosis. By fibroscan, if it is above 8, you can also start suspecting above 7. Then you do an ultrasound or a CT. You may do a liver biopsy if you plan to treat the patient. And of course, you have to see for varices, decompensation, acute and chronic liver failure, or HCC. So I have summarized before you the different aspects of the virus transmission, new modes of viral diagnostics, assessing the age of the virus, and a brief assessment of the disease. Stop here, and I will be happy if Kaushal has some questions to shoot at me. Thank
Thank
you. Can we
you.
stop?
Yeah. Thank you very much, sir, for a fantastic and lucid presentation of the natural course and how to diagnose hepatitis B. So there have been a number of questions, I think at least 50, and we picked up a few of them. And I think the question which is there in mind of a lot of person and specifically asked here by Dr. Swayambhu and Dr. Roop Rai from Jaipur is how best to differentiate between acute viral hepatitis and reactivation of HBV, especially in adult population.
Dr. Rai Sahab has always been a leader. He's ahead of time. Sir, I will come with this in my subsequent presentation, in some remaining half of the presentation.
All right. A question from Dr. Vijay Shankar and also from Dr. Waifyo from Myanmar. What is the role of serial HbSAg quantitative measurement while managing these patients of hepatitis B and especially those who are on antivirals?
It's a very important question. I will show you the role of HbSAg quant in E minus. I have not included data in E plus. Tenofovir therapy in 1 year decreases if more than 0.5 log. It is considered to be a very effective therapy. If after 3 years the reduction in HbA quant is less than 0.5, it's a failure of therapy. Number two, on interferon therapy, those who have quantitative HbA of less than 1500, there is a good chance, and genotype a good chance that they will respond to interferon. But E minus, I will show you the data.
That's a very important message that on oral antivirals, if you have a fall by more than 5 logs of HbA then these patients are likely to clear their virus. So the next question is by Dr. Thirumala. Why do we have to do both HBe antigen and hepatitis B antibody together? Is there a role of doing both together or one would be sufficient?
I will answer it in my next half of the.
Right. Thank you. And I think this is also a part of treatment, but an important question by Dr. Kailash Kole. Why don't we offer treatment to all HbA positive patients to reduce their risk of liver cancer based on their risk assessment? Why do we select?
Next part.
Right.
Next part.
Okay, this is from Dr. Jigar Patel. This is regarding FibroScan. So in your experience, you would have seen reports of FibroScan coming from both the standard EchoSense FibroScan machine and ultrasound-based elastography. Which among these two do you think are more reliable, and are there different cutoffs for them?
Well, the principles look like same. I have more experience with the EcoSense FibroScan, maybe 60, 70,000 scans and patients. So I feel more comfortable and I can interpret it. About the other machines, I have less experience, but in my limited exposure, we had both the machines for some time. It underestimates the fibrosis. So I think EcoSense in that way was better. I'm not a company supporter or I have stocks in that. One or two things you all know is that a lot of that is influenced by the NASH or by obesity and liver fats. So we have to interpret. I mean, there are limitations of this. But one thing is clear: if it is less than 6, you're comfortable. The moment it is 7, I would start worrying, and I will show you when the biopsies should be done.
Right. So this question is from Dr. Sanjeev Kumar Kar. Which one of these would you like to do in order to detect occult HBV infection? Either total anti-HBC or HBV DNA load or both?
Yeah, it's a good question. I missed it. Anti-HBC should be done in all patients, those who are HbA negative and are coming to the hospital for anything. And you will find about 10% of our population, at one time it was 30%, is anti-core positive. If somebody is anti-core positive, the next test is anti-HBS, not DNA. If it is anti-HBS positive and above 10, means he was exposed and self-immunized, never to get a vaccine. If he is anti-core positive and anti-HBS is less than 10 or undetectable, then a HBV DNA has to be done. An absence of HBV DNA does not say that he does not have an occult hepatitis B. To term occult hepatitis B or occult B infection, you need generally 200 HBV DNA levels of about 200. And HbSAg is to be tested by a polyclonal testing. Monoclonal is not done. And it's a very simple, since you have asked me the question, how do you do HBV ELISA? What you do is you have an ELISA plate which has an anti-HBS over which you put a drop of blood and it gives you a sandwich, lock and key, and gives you a reaction. But suppose the virus which you have is mutant, like it has a surface mutation, it will be negative because all antibodies are made against from amino acid 139 to 147. 8 amino acids are used when you make the antibody and you plate it on the surface. Now, one change at 145, 142 on the surface antigen, the blood containing the surface antigen will not meet. And you will say it is negative, but patient may have DNA. So a polyclonal, multiple 2 or 3 testing seras must be done, plates to be used before you say it is HBsAg negative. Then you have to do DNA, which is 200 or less, and 2 genes of the virus must be multiplied. So this is occult hepatitis B in my mind.
Right. So I
Bit
think this is
complicated.
related to the new tests you mentioned in your presentation. So somebody from Delhi, Dr. Vikas Banyal, has asked how to measure hepatitis B correlated antigen and HBV RNA. Are the diagnostic kits routinely available in India, and how much is the rough cost?
Yeah, HBV correlated antigen is a new test which is very good. It is a marker of CCC DNA replication. The kits are by Abbott on the Architect. It's available, I think, in the country. I don't know the cost. HBV RNA you have to standardize. It's a very, very sensitive and good method on when you are doing a treatment with nukes or with PEG. The reduction in RNA means the CCC DNA is also getting silenced. PEG interferon specially silences, it breaks down the CCC DNA. So HBV RNA is a very good partner, but not commercially available. You have to standardize in your lab.
Kausal, can we go now to
Yeah.
Sure. So we have a lot of questions. I think we can put them subsequently to Sir and put it on the website. So we must move on to the next part of the talk.
So you all are waiting for therapy. So what are our goals? What is the basis? And how do you repurpose? Now a term is repurpose everything. So the goals. This slide you must have seen several times, but I just want to say in the blood as well as in the liver, you have got the infectious particles, HBsAg, you have the viral DNA, viral RNA, CCC DNA. They are all present in the liver, and some of them, except CCC DNA, are also in the blood. So our current therapies, what they do is they try and clear the HBe antigen zero, convert it in about 20% or so. Then in the blood also you will see that the viral RNA and surface antigen goes away slowly, but functional cure and complete cure involves that there is nothing, and even hopefully the integrated DNA disappears. But these are all hopes. Let's see what all we can achieve. Now, some of these next few slides are the fundamental of hepatitis B. Please pay attention. It's an immune-mediated clearance. These are all hepatocytes. In a patient who has got blood transfusion related acute infection, all hepatocytes are involved. And you have CD8 T cells, which are hepatitis B specific. They will cause the cell death by cytolytic methods, in which you have T cells coming and killing. So all these are T cells, CD8, 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 they will come. They recognize the receptors, the HLAs on the hepatocyte, and they will kill it. Also the TNF alpha and other interferon gamma, which are released, they are also likely to kill cells as well as the virus. And what you read is the cells are dead. Now you have fresh new cells. In the chronic infection, the CD8 T cells, which are specific, are very thin. They can't cause apoptosis. And the CD8s actually do not bind so well. And you have a very high population of regulatory T cells. Tregs are present. And in addition, you have non-specific NK cells. And therefore, the virus persists all through. Because there is a lot of HBsAg in addition to the DNA, the CD8s are exhausted. They are trying to kill this fear of HBsAg, not the one which has the particle or cylinders they try to give. So in an adult, if you have an acute hepatitis B, you have rise in enzymes, and acute means you have more than 410 times more ALT. Most patients will recover, maybe one may die, and some may have chronicity or so. It's a vigorous immune response to the infecting virus. However, there can be a weak immune response in a small proportion of patients, about 4 to 5% who become chronic, may have cirrhosis and cancer. Now, this is an important diagram. In those who have normal ALT and have the virus, the ALT remains normal, but DNA still fluctuates. And every time it fluctuates, the ALT maybe from 15 goes to 20, comes back to 15. From 20 goes to 35, comes back. And you say, oh, he is normal ALT. But this goes on. But sometimes you get a flare. You will see that the DNA goes up first, then goes the ALT. DNA goes up, then the ALT. And Manoj had very carefully analyzed at that time our data of nearly 1,500 patients, that this occurs every 4.3 months. So the policy remains, when should I screen my hepatitis B with normal ALT? Generally, between 3 to 6 months, you just get an ALT done so that you know, is he undergoing flares or not? If he's undergoing flares, which are visible, you need to treat. Otherwise, they will be going on inside in there. Now, in a newborn baby, mother to baby transmission, why is it chronic? Because it's a 9-month pregnancy, mother is positive, and the transmission starts within maybe 3 to 6 weeks. And the T cell receptor is down regulated. The CD8s are exhausted. They cannot produce gamma interferon. T regulatory cells come up. And finally, just to cut the story short, the newborn baby becomes HBV positive intrauterine. It is not perinatal. It is not the at the time of delivery. It is intrauterine transmission, which is because of exposure for more than 6 months. So how do you treat chronic hepatitis B? More than 6 months have passed. The only way is to convert this into acute. So the whole philosophy of treating hepatitis B, which is chronic, is to convert to acute. Why? If you convert to acute, you get CD8s. They will kill the infected hepatocytes and clear them. This is to show you that in a chronic hepatitis B, like run-of-the-mill IDHS, T regulatory cells are very dominant. T regulatory cells are those which decrease your immunity. Let's say you have acute infection, you get a lot of interferon. It will continue to make interferon and the body will die. To suppress that interferon, normally, some tests to stop it, decrease it, regulate it, and that these are T regulatory cells. Now, these are identified by the flow cytometer, as those cells which are CD127 negative, CD25 positive, and they express FOXP3. Now, as you will see in controls, they're about 2% or so. And E antigen positive, maybe 4% or so. And E antigen negative, they are about 7 to 9% positive. So they are double of the normal. So they are always trying to suppress so that you do not get a flare. You do not get an active hepatitis B. And in that process, the virus persists. When you give antivirals, what does it do? So the same group of patients, the chronic hepatitis B, they are about, let's say, 7-8% or so. And these are CD4 Tregs and these are CD8 Tregs. After antivirals, they start decreasing. And this is a very important slide for understanding how we can improve upon our patients. Now here, this is the Tregs and this is the DNA. So once you give tenofovir, the DNA comes down. And the frequency of T regulatory cells, which is about 4%, over 24 weeks may come down lower. So when you have low T regulatory cells, what do you expect? Your CD8 should improve. And that is what was observed from baseline, 10% or so CD8. At 24 weeks, the number increased. And these are HBV specific CD8s. So the theory behind treating is, if you decrease virus, your exhaustion of the T cells decreases, your new CD8 T cells come, they will identify the virus and kill it. Here it is shown in this paper that you have an exhausted T cells. When you decrease HBV DNA here, you will see HBV specific T cells will gradually increase. Their T cell receptors is now redirected and they are functioning. So I hope I have made you understand simple, the body's over control of the HBV injury is to be removed. Let some injury occur and then let the virus go away. So our current therapies are giving antivirals like nukes and whatever, and then we can add on to them immune modulation, change it to immune restoration. So if you do antivirals with immune restoration, I think we can gradually decrease the DNA, also CCC DNA, with addition of other things, which we will see, we can clear the virus. Let's now come to the basis of treatment. We need to know how much is the virus, how much is the inflammation, how much is the fibrosis. And there are several scenarios. One scenario is of HbSAg positive, E positive, or E negative. They are just simply chronic hepatitis B. The drugs with us are finite PEG. Give it for a year. You have a good response. You all know it. And if you continue to follow, surface antigen loss can be up to 8%. The infinite, all your life, take it, whether Tenifo or TAF, you have to continue this. E antigen loss is about 20% or so, but sometimes it never becomes. TAF, you know the new drug, 25, 1/10 of it because it directly goes to the hepatocytes, and Tacavirisin. Or you can do a combination of these. These are our current drugs. So three things you remember: the DNA, the inflammation, and the fibrosis. Let's look at what is easy. Somebody has more than 20,000, 10 raised to power 4 viral particles, international units, and has high ALT, good immunity, good immune response. You just add on anything and the response is good. But ALT is, let's say, normal or one time elevated, 40, 50, 60. What do? You keep monitoring till the flare comes. And you treat when the flare comes, the ALT goes up. But sometimes it doesn't. What do you do? Question, big question. But if the age is above 35, if there is a family history, and there is a fibroscan which is more than 8, you need to treat such patients also. I would say even if it is not fibrosis, but the DNA is high, ALT is slightly high, one should treat. Now the problem comes in the one which is in the gray zone. The ALT may be high, but maybe 45, maybe 52, what do you do? They will come to it again. But remember, if they have fibrosis, LSM is more than 8, irrespective of ALT, normal, low or high, treat fibrosis because the age of the virus is high. Now these are the problems. There are 3 guidelines and there are controversies. In ASLD, ALT, AST is 30 and 25. Their units are 1 million, 10 raised to power 6 maybe, 10 raised to power 6. Here it is low. You have monitoring every 3 months. It is 6 months. The treatment, huge. There is a difference. They say wait till 40 years. The easel says 30 years. Apostle says 35 years or so. So I'm not going into details, but since we are in Asia and these are developed for Asian patients, I will say 40 is the normal as of now. Use 1 to 2 times elevation. Patients I treat generally at 1.2 times, that is about 48 and above. Monitor our patients every 3 months, and now 35, and a family history, we do a biopsy. Now the big question, what you used to call as inactive carriers or low replicative, we need to understand this group. And we were giving lifelong nukes. Now, this study, which is the DARE study, the daring study, which was the first of its kind, and I saw its presentation about 5 years ago, 60 E minus, just treated for 12 months. They stopped and they looked at whether these patients will lose HbSAg or not. And as you can see that a fair proportion of them lost HbSAg even at the end of nearly 2 years or so, and anti-HbS became positive. This can be beginner's luck. But this was one of the first studies to say you can stop the antiviral in E minus chronic hepatitis B. Now, this is a beautiful article by Yun Fun Liao, which has decided, he has actually combined a lot of studies and given this beautiful concept. You are giving a lifelong nuke therapy, and number of years are not known, 30, 40, 20 years, versus 2 to 5 years. Now, if you have given somebody more than 2 years or so, compare the two groups, and you have stopped. In this, you have stopped. It is a finite therapy. In this, HbSAg loss is 0.33 only if you are continuing therapy per year. But if you stop, it can be 3 times to 6 times more HbSAg loss per year in a E minus. Second, adherence is low. Here, adherence is high. In this, most people may drop out. And the fear was whether there is a relapse or viral or clinical is low. So it tells us that if you have somebody who has taken in E minus a long therapy and it is not somebody who has advanced fibrosis, has F0, F1, we can easily stop therapy in E minus. I go to the next group, cirrhosis, acute hepatitis B versus reactivation, Professor Rai's question, and third is normal AL. Now, cirrhosis, decompensated, don't worry about DNA or ALT, start. Compensated cirrhosis, more than 2000. I think at that time we said that, but today I would start anybody who has cirrhosis and Hep B antiviral. Reactivation of chronic hepatitis B, I will come to it again, but treat immediately. So, two groups don't require even DNA, decompensated and reactivation. Reactivation needs it for definition. One thing which I want to stress, and I just put this slide purposely, you are treating cirrhosis, advanced fibrosis, F3, F4 for years, but you forget to calculate reach B or whatever. Forget that they have liver cancer. Please do not, patients should not die due to complications and detected late. Now, this study is Tenifo versus Enteka. I do not know if it is a industry driven or not, but just to say, in this study, which is 19 abstract, when somebody is on Tenifo, you may have less chance of liver cancer, even when propensity matching and whatever has been done. But that is not the main purpose. The purpose is HCC must be assessed in cirrhotics, E positive, above the age of 45, and male patients. The advantages. This
Sir,
is taken from, sorry, am I running late?
No, we're not running late, sir. Just, I think one of the moderators is also watching on the live, therefore we have echo. So if we can put off all our other devices, That'd be wonderful, because there's echo coming from Dr. Narin's voice. And this was instructed by our technical team. That if you can put off, if somebody is watching on live on masterclass on the moderator side, we can stop our other side. Yes,
I
sir.
also realized I'm running out of time, so
No, no, time we
I
have.
will
Time is not a problem, sir.
We
Time
have few more. Thank you, Govind. Now this is just to show you 400,000 patients. About 100,000 were followed, and the remaining did not show up. Those who came for 3 to 6 month follow-up had 44% less liver cancer. Please remember, it is our duty. Now, decision making. Is it reactivation of B or acute hepatitis B? The labs, the clinical history do not differentiate. This is 2005 American Journal of Gastro by Manoj. Now, this is to show you that somebody who has acute icteric hepatitis is come with jaundice and is hepatitis B positive and is presenting as acute hepatitis more than 400 ALT or high ALT, let's say. What do? You do IgM. Now we do not have the titer. The high IgM is 7S and 19S positive. It is Paul Ehrlich unit. If you do, you can. We do it. It is more than 1 in 1,000. But you also can do simple DNA. Nothing more. If the DNA is high, it is reactivation. DNA is low, it is acute hepatitis B, and it is 95% accurate. The point I want to make here is that in acute hepatitis, if you remember, cells have died. Then only jaundice occurs. In reactivation, 10% of the cells which were initially infected now keep on infecting other cells regularly, and therefore cell death continues. How do you confirm? Sometimes a biopsy is needed. Today, in my opinion, all acute hepatitis B which comes is reactivation, unless you have a direct source. Now, the question was, why should we do anti-E and E antigen? I'll answer this. What are the sero profiles? At baseline, somebody is anti-E positive and DNA negative, becomes DNA positive. He becomes surface antigen positive. He was E antigen negative and now becomes E positive. He was already E antibody positive. This is called seroreversion. Seroreversion is a person who is E antigen negative and anti-E positive becomes E positive and anti-E positive. And if both are present at a given time, it is classical of a reactivation. Another rare group which you see when you give immunosuppressants is surface antigen negative becomes positive because he was anticore positive. What are the factors? Of course, case, host factors. You have some viral factors, which I'll not go into detail. One of them is high DNA mutations. But what we produce is that there is a intensity, the rituximab or high dose steroids, all of them can cause a reactivation. So remember this very well. How do you screen these people? All societies have differences, and we will have to see whether, in my opinion, every patient who is going for a immunotherapy should get. So if you go into the apostle guidelines, if the person is anti-core positive, he is not as of now screened. I think he should be screened. For all patients for chemotherapy should be screened. So I think it is important if whether you take ASLD guidelines and or EASL guidelines to check anticore before therapy. Somebody has reactivation, gets acute on chronic liver failure. Such patients, if the high MELD is there, then in those patients you need liver transplant, and those who have a low MELD can be managed, and in between 20 to 30 you will need that such patients are monitored with antivirals but listed for transplant if possible. Now the question is how to improve our current armamentarium. As I showed you, tenofovir is a reduction in Tregs and an increase in CD8. And along with this, it also causes a reduction in PD-1 and also chemokines and others are decreased. Based of a concept of giving lamivudine at that time and then gave pegylated interferon. Then the second concept therapy is sequential. Ankur did this trial, beautiful trial, where we had tenofovir followed by giving tenofovir plus peg interferon in one limb and followed by tenofovir. And the response shows that those who received that had a HBeAg seroconversion. This is a swap study. Swap means you switch on to peg interferon or you add on peg interferon or you continue with nucleoside alone. Compared to nucleoside alone, either adding or switching, purely switching, has an added advantage. The next important question is persistently normal ALT. He wants to go to Middle East for a but his ALT is normal. So the current algorithm is, if he is a young patient, just do regular monitoring. If he is old patient, we treat. Now, my aim to show you is, you have a situation and you have to treat. This guy says, sir, you are the only guy, now treat. He goes to Dr. Saraswat Madan and Govind. So the question is, can you convert him to a treat worthy? Or do we treat all? I'll come to it. But today I'll show you the reference of both of these.
Sir,
Now, this study in gut.
Sir, can I stop for a moment here again?
Yes.
You are running two devices together. That's leading to...
I am running.
Two devices. Is it two devices together? One other...
No, I am not running two devices.
Perfect.
Sorry.
Because
I've stopped my mobile also now. Is it better? I'm only running one device.
Dinesh, can you check that? And it should be okay then. It should be okay, sir.
Is the sound echoing too much?
It was echoing in between because the words become less clear, but it have been wonderful, sir.
Maybe I'll take away the mask for some time. Okay, now this study in the gut has one group is immune tolerant and one group is immune active, immune tolerant and immune active. You will see that the number of people, those immune tolerant were treated compared to immune active. Now, if you not treat them versus you treat them, the immune tolerant had more cumulative HBC if you don't treat them. Can you see that those immune active were treated, but immune tolerant were not treated, and you have more problems. So the question is, we need to have everyone to treat. Immune tolerant are at higher risk of developing liver cancer. So this was our study, and this study shows that in the beginning, all these people had normal ALT. They had high DNA. And this was done by Bimaljit Sandhu, early 2000. We gave lamivudine for 4 weeks. We brought down the DNA. Then we stopped lamivudine for a short period. After stopping lamivudine, the DNA and the ALT rose. Lamivudine was restarted. And at that time, the ALT, which was 20 or so, almost doubled up. And what it resulted was we were able to convert non-treat-worthy immune tolerant into treat-worthy. And seroconversion in E positive normal ALT occurred in about 1/3 of the patients. You can try it in one of your patients. Now we have tried this with tenofovir, we have tried this with other antivirals. Some messages in another 5 minutes I'll conclude is the new drugs. They are not available, but always future is more pleasant, except for COVID. Uh, when you have something bright for future. So this is a hepatocyte. You have entry, the virus comes inside and then go into the nucleus. We'll go into the steps in a minute's time. So what you can do is to prevent the sodium taurocholate, the transporter protein, the receptor here. And this receptor, once it is blocked, the virus will not get inside. Entry inhibitors can be. Then you have the unfolding, the capsid comes away, the virus becomes from relaxed circular, it gets inside, it becomes a CCC DNA inside where it loses its polymerase. And you have several steps here where you can inhibit them from capsid inhibitions to the replication and loss of polymerase inhibition, and you can silence it here. Then it makes it several transcription. The HBV inside the nucleus makes the 5 types of RNAs which can be taken in. All of them can be inhibited. And then of course you can have your drugs which come into the ribosome and you have them assembled from the genomic RNA converts to a single stranded negative DNA, then it converts from RNA to DNA here, and from DNA it becomes a double stranded. And your current drugs are all working as polymerase inhibitors here. And then you have another group of drugs which are your host-targeting antivirals, immune modulators, and inhibitors. So the first group of drugs are those which are entry inhibitors, and you have bulevirtide, which is available now and it works for HBV HTV combination. The next group of drugs are those where you have the RNAs converting into mRNAs, and here is the HBV virion, and the HBV virion now makes different types of mRNAs, as I showed you 5, and also these RNAs finally will release your hepatitis B surface antigen. Now, when you block these RNAs by a short inhibitory RNA, which is possible now, and you can decrease the production of viral antigens, also the surface antigen production is decreased, and because of that, the CD8s are not exhausted. And this is to show you, this was ARC520. It could reduce the HBsAg and EMG. This is the most important and promising drug. This is by J&J. It causes very rapid reduction in 1 month of HBsAg. Yeah, sound is again.
If you're using your headphone, if you can remove the headphone and if you take it that
Hello. Hello. Yeah. So it is HBsAg. Is it better?
Looks like, sir.
Okay. So this J&J drug, the HBsAg reduction can be achieved in a very short time. And what is interesting is now the triple therapy, like you have triple therapy for hepatitis C, you have nucleoside analog, you have an inhibitor, and you have capsid inhibitor, which is oral. So the 3 drugs, the one which is the RNAi inhibitor is subcu. The oral drug is one which is given once a day. And thirdly, you combine with a nuke. And now you see the beauty. Within a period of days, HBsAg, which would never come down, in a period of days, it comes down by several fold, and so does the HBV DNA. These were the earlier graphs we used to see in New England Journal when HCV drugs came. So, combination of three can bring down your DNA and your quantitative HbsAg rapidly. Just one more group of drugs, and that is the nucleic acid polymers. This is a hepatocyte which is making HbsAg as well as HBV DNA. Now, if you remove all the decoy excess empty HbsAg as well as those circulating proteins like small proteins of HbsAg, the CD8s will be directed. This is the basis of this, which is the polymers. These polymers are given along with tenofovir and peg interferon, and in almost two-thirds of them, the HbsAg decreased to less than 1 international unit. So what are our future things? The current is you have inhibiting the viral replication. You have several drugs. You have now to see that lower viral antigen levels come. For this, you can use small inhibitory RNAs and you can use many other drugs. So you have fewer empty particles, fewer complete particles. Then you need to boost the immunity of the host, and that can be done by several drugs like TLR, RIG1 agonists, PD1, PDL1, all other inhibitors and others. So this is my last slide. The carry home message is hepatitis B therapy looks possible. The impossible looks possible. But we must understand that patients have not to be given a name of hepatitis B carrier. This is absolutely insulting. No mistake of theirs. They are born in a family where mother is positive. Don't label them as a thief or a culprit. So don't use carrier. You can use any, I'm not saying, but possibly you can use chronic HBV infection like chronic HIV, chronic HBV, or anything, HCV type, or you can use an acronym which very few understand in non-medical terms, IDAHS, incidentally detected asymptomatic HbsAg positive subject. You have to assess every HbsAg positive with fibrosis, stage, age the virus, you have to see the ALT, level of inflammation, flares, you have to follow them sometimes, and the type of virus, mutant, non-mutant, and the quantity. If the person is E positive and is more than 1.2 times, my theory, it may be wrong, but it shows that don't wait till 80, don't wait till 60. Above 1.2, most trials have taken patients. So ALT above 48, you can start TAF, and you wait till she becomes E negative, and 30% may become in 5 years, or sometimes less. Sometimes it has to be lifelong. But the better approach is after the viral load has come down to, let's say, 210 raised to power 3 or 5 or so, you can start immune restoration by giving peg interferon. I generally do it after 6 months, 3 to 6 months. Viral load has come down, and then peg can be started for a 48 weeks. If the person is E minus and has taken nukes for 3 years and is less than F2 and ALT is normal and DNA is negative, you can stop and then follow. You have to then monitor for both groups DNA. Once DNA is negative, then the CCC DNA application you can measure by surface antigen. If it comes less than 100, it is safe. In reactivation, diagnosis is based on high DNA. You may need a biopsy and you must start nukes immediately. Every cirrhotic must be monitored. Now the question is, should we vaccinate all? Yes, everybody has said, not the patient, but all the guys who have not been infected. The question we must answer, and I have a strong feeling for last 20 years, treat all. You treat all HIV, you treat all COVID if the drug will become available. Why not treat all hepatitis B? My last two slides are, because I won't get an answer, but I want to know how many of you, gastroenterologists, hepatologists, physicians, surgeons, are immunized against hepatitis B. Because this was given in Rajasthan, but I would like this to be for the country. Vaccination is not equivalent to immunization. If you have been vaccinated and you don't know your antibody, it's not acceptable. Every healthcare worker must have antibody levels above 100, not 10, because they do decline over time. And non-response is seen in 7% of healthcare workers. So my suggestion and request is get your anti-HBs done. It shows that you have good immunity. Maybe your anti-HBs above 100. You may also have good antibodies against COVID if at all you get exposed. Just an idea. Thank you all.
Thank you once again, sir, for that fantastic
Yeah.
presentation.
I think I'd like to thank you very much for the presentation, sir. We've really enjoyed listening to a lot of questions, and over 400 questions, 350 questions have flooded in. So I don't think we'll have time to take all of them, but I'd like to start off with some of the important ones. The audience that you have gathered is pan-Indian. Myanmar, there are a lot of people who are listening. Uh, Interestingly, Colonel Krishnan is listening and enjoying your talk from Chennai, and he's got a very basic question. In your experience, what is the impact of hepatitis B vaccination on new cases of HBV and HCC in India? I hope you've got that, sir.
When we started our training, hepatitis B was ranked as about 4.3%, but the latest graph in 2019 in Gastro shows India is less than 2%. So I think vaccination has made a difference. We haven't got a large cohort of studies, maybe ISG can do it. It has an impact definitely on the prevalence of HPSAG, whether HCC. I also feel, in my experience, they are less.
Right.
Number of patients are
Right.
less.
And Dr. Jayanti from Chennai, what are the virologic differences between vertical and horizontal transmission? And also Dr. Akash and Dr. Ankit from Chennai and Chandigarh want to know, is there a difference in the natural history of HBV infection acquired vertically versus horizontally in the perinatal period?
The virological differences are huge. E antigen positive mother will transmit virus as E positive. The newborn will be E positive. Mother is E antigen negative, can make a baby E positive because during pregnancy, the virus can convert in utero from E minus to E plus. And this is a New England paper by Masao Omata of a fatal case of neonatal death due to acute hepatitis B in the baby. Second, we had a Lancet paper where the mother was positive. We gave the lamivudine prior to pregnancy, continued pregnancy with E positive and lamivudine, no breakthrough. The baby was born with HbSAg negative because HBig was given. Now the baby had very high ALT and a DNA of 1 picogram. Baby had chronic hepatitis at age of 9 months on biopsy. So your question is there a difference in E positive and E negative? Certainly E positive transmits as E positive. Intrauterine pregnancy can make the virus active. 3, E minus, if it becomes E positive in pregnancy and at birth, can be fatal. Now, the characteristics of the virus which acquire from horizontal or vertical, virus does not change. It's a very slow virus. The error rate is about 1 in 10,000, and therefore the chances of mutation in first 6 to 8 weeks are low. In acute, you don't have mutations, but in chronic, mutations can be very high. There are 12 mutations from 1814 to 1900, and the most worrisome mutation is those which are occurring early. The horizontal transmission, little fear, vertical, huge.
Thank you, sir. I think very useful information because people are not very clear about the natural history and outcomes by these two routes. Another question that is a bunch of questions actually regarding E negative chronic hepatitis B. And I think Dr. Chandan from Chennai and Dr. Akshay from Nanded want to know why is E antigen negative disease becoming more common in India? That is one. And does E negative always mean a mutant, or this could be as a part of seroconversion and natural history? And how does one differentiate between the two?
The E antigen is more common because anywhere in the world, the E positive rates are 10 to 12% only. 80 to 90% all over the world are E minus. This is the way the disease has been. In India, still about 30% are E positive, 70% are E negative. So we are still better off. The disease is not always aggressive except where there is a strong family history. 2, person is obese. 3, there are huge mutations in the virus. As far as the natural history of E minus in India, and are they always mutant? I would say that E minus in general is a mutant. E minus in general is a mutant. What did I do? Can you hear me?
Yes, we can, sir.
Yes, we can, sir. But the screen has gone. Can you see me?
Visible to us on the screen, I think.
Okay.
We can see you, sir.
Sorry.
We can see you.
Yeah, is it okay?
Yes, sir.
Yes, we can hear you and see you, sir.
E minus sometimes has natural history wise more aggressive, especially in the families where there is a history of HCC. Majority of India has E minus.
Thank you, sir. I think there is a good question from Dr. Lodenio, who's from Kenya. He wants to know what makes genotype D more difficult to treat. And Dr. Abhinav from New Delhi also wants to know the role of genotyping before initiating nucleoside analog treatment. Should we be doing it routinely? Will it help us in the choice of the nucleoside analog?
These are questions close to my heart. I thought people will never ask because genotype D is a mutation which occurs at site 1896 or 1898 in the pre-core region. And at this region, if the mutation occurs, it is a stop codon. Therefore, E antigen production stops, but not the virus. The virus production continues. On the other hand, this genotype D is non-responsive to interferon because this area does not express the epitope, immune epitope for interferon sensitive CD8.
Okay.
Normal seroconversion occurs in the basal core promoter and core promoter, which is at 1762, 1764. This is natural seroconversion, which is unstable. 1896 is a stable mutation, irreversible, but 1762, 1764 is unstable. But it is unstable because there are epitopes for interferons to work. And this is genotype A. So genotype A, in simple terms, is permitting interferon sensitive epitopes to come up. It is a transitory thing and it is therefore interferon responsive. Genotype D is a stop codon, never to change. And therefore, the virus multiplies, continues to fool the body and does not allow the interferon to come. I hope it has answered in simple terms.
Yes, sir. And so the role of the routine genotype testing, do you find a role before choosing drugs?
Anybody who is going for interferon, I think genotyping is good. Anyone in the family with history of HCC, genotyping is to be done. And if two brothers or siblings are there, it means there is a positive family. Positive family means index patient plus one. If there is a positive family, genotyping must be done. If the husband and wife, there is transmission, genotyping is a must.
But for nucleoside analog therapy choice, it may not be necessary.
Not needed.
Right, sir. I think there is a whole series of questions. I'll just try to put a few of them regarding the role of quantitative HBsAg testing in choosing a treatment candidate, in stopping treatment, in monitoring treatment. Can it replace quantitative HBV DNA testing? Are some of the questions regarding this marker.
First, the commonest use, if HBV DNA is negative, how long and with what can you monitor? Only one test, quantitative HBsAg, which is marker of CCC DNA replication. So please do not use every time quantitative HBsAg if the DNA is still high. Baseline and maybe once a year. If the DNA is negative, this is the test every 6 months. 2. If you are using PEG interferon, the selection of patients who will respond to interferon generally should have quantitative HBsAg of less than 1500 and genotype A. They will respond very well. Those with nucleoside analog, at the end of 1 year, if the reduction is less than 0.5 log, then it is unlikely this patient will respond. And if at the end of 3 years, it is less than 0.5 log, it's a failure of therapy.
Right, sir.
Right.
Okay.
Kaustuv,
Couple of one or two very interesting questions are from Dr. Avinash Tiwari in Sher Kashmir Institute and from Dr. Shifa in Madurai. Any experience or what are your gut feelings about chronic hepatitis B with COVID superinfection? And any cases of ACLF due to COVID superinfection in a chronic hepatitis B carrier? What are your thoughts there, sir?
There are large series which have been recently published in Hepatology International, series of, and there is a large policy study which is under preparation. The current data is the reactivation is about 2.3 times more, or severity is 2.3 times more in those who are chronic HBV infected. How does it reactivate COVID? HBV is not clear, but most likely the mitochondrial stress. You know that in the hepatocyte, mitochondria make 30% to 50% of the total volume of a hepatocyte. So when the COVID comes, mitochondria is under huge stress, and that stress transmits to the nucleus and makes possibly the HBV also replicate. So current thinking is people with chronic HBV infection are at a higher risk than others.
Last question from my side before Kaushal takes over with these. I'm sure he's got a series of questions as well. Is one of Dr. Bhavesh Booth, who's doing his DM here and is from Bhavnagar, wants to know, is there anything like an integrase inhibitor, like CCC DNA, prevent integration of DNA into the human genome?
Well, CCC DNA inhibitors are specific. You know, what you need is to chop the CCC DNA to make it open. And your ApoBec 1 and ApoBec 3, both are known to open up the CCC DNA. And ApoBec is stimulated to some extent by interferons, but of course many other drugs. And now the new therapy, CRISPR-Cas, you can cut and open up and patch the sequence of your choice. But there are a couple of drugs which are in the development by GSK. One of my slides, if you go, where I have shown the J&J drug, there is a list of drugs on the left side which can open up the CCC DNA.
So the question was to block integration into the human genome. your integrated virus gets in to the genome? Can something block that integration?
Very interesting question. Do we have time? Okay. The integration will occur as a random. I missed the question. Normally, cccDNA in E positive is about 1 copy per nucleus. And in E minus, it is 0.5 copies per nucleus in a chronic HBV with normal ALT. The moment virus multiply, the hepatocytes multiply, the cccDNA also increases. So in acute hepatitis B, you will have something like 50 copies in the nucleus of cccDNA. Now in reactivation, this number exceeds 50. The moment the number exceeds 50, the virus will integrate into the host genome. The host genome integration is a space crunch.
I see.
And therefore, you must have replicative hepatocytes, whether reactivation or acute hepatitis B, for getting. It is not in chronic B that integration will ever occur. Integration will occur when there is a hepatocyte replication.
Thank you, sir. Excellent insight and knowledge that you have got. Marshall, please, I'm sure you've got questions. And Govind is sitting there. He'll tell us how many more he will allow.
Kaushal, we can ask 1 or 2 questions because we are about 1:30. So we'll have to close. But 1 or 2 questions should be. You're mute. Kaushal, your mic is, you're muted.
Sorry about that. So I'll just ask 2-3 very pertinent questions. So one is by Dr. Gautam and Dr. Bhavik. Any role left for TDF now in the era of TAF? Should all patients who are on entecavir or TDF be switched over to TAF? Because that's a very common practical clinical problem.
I cannot answer this. There is no large study of switchover. There are 2 studies which have shown that if tenofovir is switched to TAF, you can continue this despite renal impairment. So there is possibility of switching over. Entecavir, whether you give 0.5 or whether you give 1, depends. If there is 0.5, I would continue. But if there is a need of 1 milligram entecavir, means there is resistance or something or a patient, I would certainly switch on to TAF. So 0.5 Enteca can continue. Others should shift to TAF.
A very important point you, I think, clarified. Another important issue, because the data you presented was a bit provocative regarding intra-utero transmission of hepatitis B. So that has raised many questions. And one of them is that if that is really true, do you recommend starting treatment in the first trimester of pregnancy? Why wait till the 3rd trimester or perinatal stage? This was from Dr. Akash.
Yes, I wanted it to be provocative because we have for last 10 years shouting and shouting that this is the way. So I'll give you answer for 2 reasons. We never used to think that the vaccination and antiviral should be done during pregnancy. Now this has come up, there is a meta-analysis clearly indicating this is intrauterine transmission. So you can give vaccine as well as antiviral in the pregnancy. 2, all of us have been giving, and there are trials that if you give prior to pregnancy, somebody who is taking antiviral, it should continue. I personally give to all our patients tenofovir in the first trimester because the transmission occurs at 6 weeks of intrauterine life. The aborted fetuses in Chinese study, when they were taken out at 6 weeks, showed intrahepatic replication of full virus. So one should definitely try and treat at first trimester. We need a large study.
Very important message. And just one last question. I think we can close after this, although there are a number of questions. This is from Dr. Girish. So patients who are supposed to undergo emergency surgery are supposed to receive chemotherapy maybe in next couple of weeks, and they have very high viral load. So what advice do you give them?
Suppose person has to go for a resection, for a surgery, and a load is 10 raised to power 9. You can give dual antiviral. I did not discuss, but there is a gastroenterology paper by Ed Gain that if you give two antivirals, you certainly achieve a faster viral load reduction. That is also applicable in patients who have got acute and chronic liver failure with high viral load. So dual antiviral can be tried in such patients, although data is very, very small.
Thanks. Thank you, sir. I think we'll hand it over to Dr. Govind from here. Thank you very much.
Thank you very much, sir, for a wonderful, wonderful talk. I think all of us have learned quite a deal about hepatitis B virus infection, from basics to advanced in hepatitis B virus. It has been a masterly talk by you, sir, and I think everyone enjoyed. We have a 1900 plus viewers today. We have been streaming on Masterclass, ISG Masterclass, and also on the Facebook Live. And we have a number of people on Facebook Live also. And the popularity of your talk, that we have almost 380 questions. Some of them have been asked by Dr. Saraswat and Dr. Kaushal, but probably we'll send you these questions. And if you get time, if we have some answer, then it will be great that we upload. What we have been doing for last many talks, that whatever question remains unanswered, we post to the speaker, and they have been very kind to give the answer to those things. Thank you so very much, sir. I mean, it has been really, really great for ISG and for all of us to listen to you, your wonderful talk. One more thing, Dr. S.K. Thakur from Patna wrote that he enjoyed the talk very much, very impressive, very informative, but not only he, but everybody else missed your charismatic smile. Thank you so much, sir. Now coming back to the word about the feedback we had asking you about last talks, and we have some good response coming from about 140 participants. They like the program very much, and they want us to continue on this program in the future also. So we request we will send this questionnaire again to you. Please respond to us to those questionnaires so that we get those feedback, both positive and negative feedbacks. More importantly, the negative feedback, that how you didn't like and how could we improve the quality of these master classes, will help us in improving the bar of these master classes. All of you agree that all 6 topics which we did till now have been wonderful speakers, and all of you have enjoyed it. Furthermore, the previous talks which have been delivered in master classes are being uploaded on Facebook and ISG Masterclass, so that if you have missed, you can view them again. Today, our apology for echoes in our voice. We check with our technical team just after the meeting out and see that what was the fault. Our due apology that there have been echoes during the presentation. Now coming to our last part, that in the next series of this master classes, we will have a next talk on this Wednesday by Dr. Rakhi Maiwal. She's from ILBS. She's a professor of hepatology there in ILBS, and she will talk to us on very, very important topic, that acute kidney injury in patients having liver cirrhosis. And this is a schedule on coming Wednesday, that is May 6th from 5 to 6. Thank you, viewers. You have been wonderful in your questions, and we thank everyone who have been participating in these webinars. Thank you, our technical team, and thank you, Sun Pharma, for supporting this. Thank you very much, and bye-bye. See you on this Wednesday from 5 to 6.
Thank you.
Thank you so much. Thank you so much. Bye-bye, sir. Thank you so much, sir.